to start. Obviously, the more cutting you do, there's a risk of bleeding and there's a risk of inflammation, a risk of scar tissue. So there's always going to be plus and downside. Otherwise, we would never do stenting. I like the stent, especially with cataract surgery, because the recovery is faster. There's minimal bleeding. It's very clean procedure. But I would wait until we're comfortable with doing the mixed procedures when we're learning, I would say. Between iStent and Hydrus, I think that we need to do more studies. I think they're reasonably comparable now that we can do three stents, at least in North America, versus one Hydrus. Hydrus, I would say technically there's a different learning curve, but when we're in, we're in. We know we're in the canal. With iStent, I think the learning curve is shorter because you're pushing the button and releasing it. But
You mean the second generation Einstein?
second generation iStent, yes, second generation. Yep, exactly. But still, there's a challenge to know how deep you are. Are we too deep, too superficial? There's a little bit of that challenge to know that. So they each have their own learning curve. And yes, first generation iStent is a bit trickier. I did a lot of those procedures in my career. I've gotten used to it, but there's a learning curve for that. So I think with iStent, most people are using second generation or third generation iStent. And Hydrus, I like a lot, but it's more involved as far as learning the placement of it. So that's kind of the different options we have as far as where to start from and maybe where to continue to.
Okay, and the one more question. So, based on your anatomical presentations, when you see the blood, because what we tend to do as a surgeon, when you see the blood, you try to run away from that zone area. So, what you're trying to say is that if you see the blood, it's better to stick to that area because it has a higher chance of success.
Well, again, it depends. I mean, for example, if you have a view of the TM and you have patchy blood, so blood is here and here, a few areas where it's there, then that probably tells you that there's some form of collector channel behind there.
I see.
So placing a device nearby, maybe just next to it or something, probably a reasonable idea. I don't have any evidence to prove that, but I feel that that probably indicates there's some patent collector system in that area. Because if you're putting a stent in, it's only going to cover, one clock, maybe not one, maybe 2, 3 clock hours. So put it in the area of that. Now, the reality now, Imran, is most of the time we're putting 3 stents in now, or more than one stent. So we basically can put multiple stents in now, or now we have excimer laser, Elios laser, which is excimer laser. We can put 10 shots. So now we can cover a large area, but it probably doesn't matter so much where do we target because we can put so many in. We can cover a larger area now.
I see. Okay. And the last question is regarding when you do the surgery with the phaco or alone. So I assume when you're going to do the phaco, you have the dilated pupil, and that does it obscure your angle more because of the thickness of the iris?
No, no, because viscoelastic will deepen the anterior chamber and there's no problem. I do it no problem. I don't worry about the pupil size. I don't put myocol in to constrict the pupil. That was something that people talked about before, but we do not do that at all. No need. Viscoelastic is more than enough to create the space.
Okay, and you recommend to all the beginners to use the cohesive one.
I think you're right. Cohesive probably will create space better, so it makes sense.
Okay, okay,
I
thank you
agree.
so much. Great.
Yeah, keep it up. I mean, I'm glad you're doing these things. I mean, we need to continue to learn and do more, and particularly learn in places that we all work in.
Yes, we have some questions in chat.
Yes.
Dr. Rossio Spencer, I think he's from Globals. What was your worst complication and how manage?
Well, like any procedure, there's always a risk of complications. I'm just going to show you one video from one of our fellows, just to show what can happen. Because these are topical anesthesia, if there's a lot of patient movement, then what can happen is you can get the iris, and if you look closely, you're going to see it's not very nice, but there's a fairly large iridolysis and some bleeding, right? So that can happen. That can happen, and that's a risk. The other things that can happen is that we can end up, for example, let's say here in this example here, very difficult view. Okay, this is what's going to happen when you learn. Everybody, we got a poor view You're pushing on the cornea with the lens. You have to let it float. It's like doing gonioscopy in the clinic. You push too hard, we're going to get striae. So it's just floating float like a butterfly, right? And get a proper view. But we don't know, and we have a top-down view. We're looking down into the angle. Remember that I mentioned top-down view. So the surgeon's going to, place the KDB here, but because of the top-down view and the view, you're going to see there's a question. Where are we? And what happened here is actually the KDB ended up going below the TM. So where is that? That's creating a cyclodialysis cleft. Okay? And you see here, unfortunately, look at the cleft. It's underneath the TM. The TM was not cut. It's a cleft here. So you have to know the anatomy, have to visualize properly. But look at the cleft that's occurred here. Patient had a cleft, has hypotony now from that. Yeah. Okay, so that's something that is happening. So those are some of the complications that we see. When we are doing GAT, passing the catheter, the suture, we don't know where we are. We're passing it. It could go suprachoroidal. It could go into the anterior chamber. In this case, look what's happening. Look closely where the suture is. It's going into a collector system. Look at this. The suture went into the aqueous vein, right? So that is one of the challenges when we do a blind pass of the suture. This is another cool example where we passed the catheter. Where are we? We're not paying attention. You know where it is? Look where it went. So far posteriorly, because it went suprachoroidal. That is one benefit for eye track, because we can see where it is, but we should have paid attention to see where it is. And it wants to continue to go back there. So then we're going to go the other way, and now we stay in the canal, and we're good. So these things can happen. You can imagine with a suture, we may not know where we are because we don't have any direction of that. But with a lid tip, you have that ability to see that. So I think those are some of the more serious complications that I would say that we worry about with mixed procedures. But they're fortunately rare. But like anything else, there can be complications. Yes.
That's interesting because it's like a dacryocystomal rhinostomy when you put the stitch into the collector canal. It's like trabecular collectorostomy.
Yes, maybe that's a new technique we can use.
Other questions there. Omni versus eye track.
I mean, they both are similar. They both viscodilate. They both cut. But eye track is more viscoelastic, right? And with eye track, you have the light on the end. But with Omni, it's you do the injection by yourself. It's very slick to do that. You don't need a second person to inject for you. With eye track, we have to do a nurse or assistant to actually do the injections by twisting. So, there's simplicity with Omni, but more versatility and accuracy with eye track.
What about efficacy profile?
Efficacy-wise, I mean, I believe that they're fairly similar. Even though you can do more viscoelastic injection, we don't know whether viscoelastic injection makes a big difference or not yet. So I think what's more important is whether you do a trabeculotomy with it, whether you're cutting or just viscodilating. Most people were doing viscodilation and cutting. But you can do it with either one. I don't think there's a big difference if you do it well with efficacy. However, if the catheter is in the wrong place, there's more complications. And with eye track, you just know where you are. That's the benefit of it. If you do too much viscoelastic, it's also a problem as well. But that's a matter of deciding how much to put in.
Another question. If we put in ABIC procedure the stent inside the Schlemm's canal, but now it's not possible. I don't know about that surgeries, but if we put the stent inside the Schlemm's canal, ab interna, what do you think about the efficacy? Will be the trabecular pressure lower than
as long as you don't remove the trabecular meshwork in some area, you can put a stent in. If you do 360-degree trabeculotomy, of course, there's nowhere to put the stent, right? But if we usually do a partial. So if we do viscodilation and stenting, I like this. I believe that the results are more effective in my hands. But do I have the evidence to prove it yet? No. There's some retrospective studies which show some trend, you could say, perhaps to show more improvement with viscodilation plus stenting than stenting alone or dilating alone. But we have to do more data for that, I'll be honest. But I love the idea. It certainly makes the stenting easier, in my opinion, and more predictable.
I always thinking about that when we do the GAT or Omni procedure that we know about study fibrosis, some fibrosis happening, and
Mhm.
other things. Uh, we not doing trabeculoectomy, we're doing trabeculotomy.
Mhm.
So some parts of the trabecular TM and the
It may
external
close.
the mucosa that just blocked the collector channels
Yes.
sometimes. So that's why I think that ABIC more conservative for trabecular meshwork. This surgery more safe, more better, but to structure, trabecular structure. So I believe that if it's possible to do this surgery, ab interna canaloplasty with eye track systems, with implantation in the future. Now not available, as I know.
Mhm.
No implanting any stents or sutures to just pulling inner
Yeah.
wall of Schlemm's canal, and there will be some other mechanisms like increase uveal outflow also.
Yeah. Yeah. No, I like to me, I like the idea. And I do this now. I do viscodilation with stenting. I do
Oh,
both. I do both, yes. A lot of them I do.
internal, ab
Yeah,
internal.
ab internal, ab internal. Yeah. But the question becomes cost, right? And obviously, as well, do we know it really makes a difference? That's what we need to have more data. But I do like the idea. We commonly do it. Like I said, it actually makes the stenting to be more predictable as well, I believe, because you have the canal dilated now,
Yes,
So
yes.
my
Uh,
thought.
well, one more question. So we know that when the patient has used a lot of drugs before the Trabec, and it has less efficacy due
Yeah.
to fibrosis. So what are your findings in with MIGS?
I think it's similar, honestly. If someone's on drops for so long, chronic drops, drops are what we use for glaucoma, but I think drops are also bad, unfortunately, right? Because drops create more inflammation. They cause perhaps some underperfusion, all kinds of concerns around toxicity with preservatives. So they're not great, unfortunately. I mean, we use them because they are quote unquote feel to be safe, but they do lead to these chronic issues. So that's why for MIGS to be effective, it's better to use it earlier. But that means we have to be comfortable using it before all these drops are used, before patients are on 10 years of drops, with 3 drops and all this issues around the eye and in the eye. So, but I do believe there's some correlation with that. You're right. And that's why we have to think about you moving MIGS earlier in the course of disease because the efficacy will be greater, I believe, than leaving it till the end with multiple drops and issues around that. So this is a very topical issue. That's why we think SLT laser is a good choice to use rather than going to medications first, as one example.
Yeah,
I
thank
think
you.
you use the Jacobs 1 Gonier lenses, and you pull the uh, forward to the microscope, the eye. What type of the anesthesia you use?
Topical, just topical anesthesia.
A patient not
Uh,
having feel anything?
no, there's minimal. No, I mean, it's topical anesthesia. We're not really pushing the eye around. We're just placing it on the cornea and we basically move the head around. We don't move the eye with our hands because you cannot, right? You just can only hold the lens there, use the incision with the instrument, tilt the head a bit. I pretty well do 100% topical.
Your patients very good patients because our patients is always
Huh?
moves fast and
We
no
just we,
stop.
we just we just we just slap them like this, slap it. No, we don't. No, I mean I think it depends on your patient profile. I mean, you can block them if you want, but that's not going to change their head. If they're doing this, then that's not going to help them, right? And if they're moving the eye everywhere, I generally find if I talk to the patients, and honestly, a lot of the factor is how you talk to the patients. I meet them before and I say, hey, listen,